Adolescent gynecology is a really big topic, so I just kind of chose some things in it that I thought might be good for you guys, and then it may completely not be what you want to talk about today, but this is what I wanted to talk about. So, so it's kind of a combination of things. Okay, so I don't have any disclosures for this. We're going to talk about understanding etiologies for menstrual disorders, because you know what? Menstruation's super important in women, and it's one of the main things that you guys will get, consults about with menses that's not there, menses that's irregular, menses that are not irregular, menses that are heavy. It's basically like 90% of gynecology, so we'll talk about that. And we'll develop a little bit of a way to kind of filter through to see what you're worried about in the end. I'm not going to talk about treatments because I think the treatment option in different countries varies a little bit depending what's available, but at least we'll understand kind of how to get there. And then I'm going to talk about adolescent contraceptive use and unintended pregnancy, which I know is also a little controversial in Indonesia, but it's important that you know about it. And maybe you can kind of open your mind a little bit to think about kind of how you can apply global standards to maybe an Indonesia context that might help kind of improve maternal morbidity and mortality and women's health in Indonesia. Because not only, it doesn't happen that global standards always work in a country, but at least you can hear about them and see what might work for you. Okay, so it's really important to know kind of when different characteristics happen in girls, because you may get a mom or even a girl coming to you and saying something's not right, things aren't normal, and maybe they are really normal. So the average age of menstruation is actually 11, but you can see that there's a huge range of when it's still normal. So we're even seeing girls up to 9, but it kind of depends on the situation. In higher income countries where obesity is a problem, we're seeing girls have their periods much earlier. And then you can see here that it's still very normal even to not have a period until they're 16. But typically they're going to have some other characteristics. So the first thing that happens for girls is pubic hair. So before menstruation happens, they get hair. Not typically under the arms, but pubic hair. So that kind of happens first. And then you can see the arm hair happens kind of much later. And then they start getting some breast development before menses happens. And then they also may, about the time that menses happens, or slightly before, get a growth spurt. So the first thing that's going to happen is pubic hair before anything else happens. And it's important to remember that, because if you have somebody show up with no hair and then they're 16 and they haven't had a period, you need to be thinking that maybe they have some sort of genetic reason that that's happening. Now, normal menstruation, which it's put in parentheses, normal, because normal has a really big range. And so the range of duration of bleeding can be anywhere from 4 to 6 days, but then also it can be less than that and a little bit more. Usually most of the blood that comes out happens in the first 3 days, so women will report that their bleeding is heaviest in the first 3 days, but not necessarily. And then cycle length has a huge range as well. So most people are between 24 and 34, but you can have 21 and 40 days being normal. Now, what's interesting is for teenagers or adolescents, they may not have regular menses for a couple years. So they might get their first menses, and then they may skip a lot. And that's normal. So it takes a little bit for that kind of the hypothalamic pituitary axis to all kind of work well. Some girls, they get their period and then it's regular from then on, but most girls have some skipping that happens in the first couple years. Now, the average blood loss in a period is about 30 milliliters, and we consider above 80 being excessive. But interestingly enough, this has become a definition that is evolving, and now globally that 80 milliliter cutoff may not be kind of the cutoff we use. The cutoff that people are using are, does the patient think it's heavy? So if the patient thinks it's too heavy, then that may be the definition we're using. So people are kind of evolving as shared decision making and having more involvement in healthcare changes for patients. So what about the definition for bleeding? That's changed over time too, and that's why you see that strikeout happening here. But I don't know, are you guys trained on these terms? Abnormal uterine bleeding, dysfunctional uterine bleeding, menorrhagia, metomenorrhagia, okay. And then amenorrhea means no bleeding. If it's primary, that means no menses by age 16. But if they have secondary sex characteristics, you're not so worried, but if by age 18, if not. And then secondary is no menses for 6 months. So they had menses and then it stopped for 6 months. And then oligomenorrhea means that you don't have very many cycles. And then polymenorrhea means you have a lot of cycles. So what's interesting about this is these three terms are considered outdated now. So there's a new format from FIGO about using different terms, which actually is kind of a hard, I find this to be a hard thing to change to. But this is the FIGO classification for abnormal uterine bleeding, and the reason why they wanted to change the classification is because they wanted to be more specific about what the abnormal uterine bleeding was caused by. So this is the new terminology for abnormal uterine bleeding. So you still use amenorrhea, you still use oligomenorrhea, but for things regarding kind of heavy bleeding, this is the new terminology, and it's called the Palm-Cohen terminology. And PALM stands for polyp, adenomyosis, leiomyoma, malignancy, or hyperplasia. And then Cohen stands for coagulopathy, ovulatory dysfunction, endometrial, iatrogenic, or not classified. Okay, so let's practice this, okay? So this is how you can practice this. So we have a 25-year-old G1P1 who, with abnormal uterine bleeding, and her abnormal uterine bleeding is because she has fibroids and she also is anovulatory. So basically, she has a structural issue. So you can see here in the palm part, she has a 1 by leiomyoma. And there's a subcategory because her leiomyoma is submucosal. So that's that SM. And then in the Cohen part, she gets a 1 on the ovulatory because she has ovulatory dysfunction. So if you wanted to shorten that up, because you don't want to write that all out, because 0 means that she doesn't have anything in that category, then you would say abnormal uterine bleeding, she's LSM:O, all right? So again, that's how you would do that, which is kind of complicated rather than saying menorrhagia, but menorrhagia doesn't really tell you what the menorrhagia is from, right? So they're trying to get more specific to help with studies, because in studies, when somebody just says menorrhagia, is that from fibroids? Is it from ovulation dysfunction? Is it from adenomyosis? They really want to make sure that they know what the heavy bleeding is from. So that's why they're changing the category of it. Have you guys heard of this before? Yeah. Are you using it? Yeah. Oh, you're using it. Okay, great. All right. So the #1 cause of abnormal uterine bleeding or oligomenorrhea in a teenager is pregnancy. It's the #1 reason. Okay. So you always, if you have an absent period, if you had regular periods and now you have irregular periods, if your periods are lighter, the #1 reason is pregnancy. So this is the first thing you should think about always in a young woman or an adolescent. You should also just think about it in general for women in reproductive age. Pregnancy is going to be the most common thing. And it's pretty easy to test for because you can just do a urine pregnancy test. Do you guys know this movie? Yeah. All right, so when we think about kind of how ovulation, menses, menstrual dysfunction, we have to think about kind of where the problem is happening. So this is kind of the methodology of how to think through. If somebody comes in and says, I have a problem with my period, then you need to think through, is it something with their head that's happening? Because the head talks to the ovaries. So, and then in the head, there's kind of two different places. There's the hypothalamus and the pituitary, and then that talks to the uterus and the ovaries. So you're thinking through kind of where is the problem. Now, the first thing to think about to know where is the problem is, are they ovulatory or not? So are they having eggs come out every month or are they not? Because knowing if they're ovulatory or they aren't helps rule things out. So do they have an ovulatory pattern or do they have an anovulatory pattern? Now, sometimes you can have two things going on, like that patient that I just used as an example. She had fibroids plus she was anovulatory. Now, do fibroids make somebody anovulatory? No, fibroids don't do that. Fibroid's an anatomical problem. She had something else going on. So in any case, you need to make sure, are they ovulatory, are they not? Okay, so if ovulation is present, then the head's working fine, and the head is talking to the ovaries fine. So that's all okay. So what's not okay is basically, so first of all, if you're looking at ovulation, the clinical signs of it are Mittelschmerz. So people report pain with ovulation in the middle of the month. Not everybody, but some women do. So that can help you. Women who have symptoms around their period have a very high rate of ovulation. So if people report, yeah, I get some breast tenderness, I have some cramping, I have symptoms around my period, most of those women are ovulatory. Regular cycles, and then if they've had pregnancy before, you know that they've been ovulatory before. You can look at the temperature rise from progesterone production, although oftentimes that's really hard for women to track, especially in warm areas. And you have to use a special thermometer. You can't use just a regular fever thermometer. You can do a day 23 progesterone level, and if it's 3 or above, then that's really indicative of ovulation. You can do an LH test kit, which is kind of like a pregnancy test for ovulation. Do you guys have those here? Yeah? Okay, so you can check for that, although you do have to have like a really narrow window where they're checking, so sometimes they have to check the whole month if they don't know for sure. And you can have women that are normally ovulatory and then skip a month now and then. So if you have somebody that's tracking ovulation and has 2 out of their 3 months be positive, that's normal. Either they missed their window or they just didn't ovulate that month, and that's okay. You can do an endometrial biopsy to show secretory endometrium, but we just don't really do that anymore because it's uncomfortable, but that is one way to see if somebody's ovulatory. Okay, so if ovulation is present, so if you were like, yeah, you had regular cycles, you sound like you're ovulatory, like what's their differential diagnosis? So it's going to be pregnancy because all of a sudden things stopped. They have a coagulopathy, and that's why they're bleeding heavily. Infection, or they have an anatomic problem. So it's all kind of uterus related. So everything's working up here, their ovaries ovulating, something's wrong with the uterus. So something's causing a problem with the uterus. So that's kind of what that means. So that makes it very easy. You just ruled out a bunch of other things happening and went right for the uterus, right? So if you know that they ovulate, it's a uterus problem. So one of those most common things for heavy bleeding is von Willebrand's disease. I know that in populations that are of East Indian descent and Caucasian, it happens pretty equally. I don't know in Indonesia, do you have a high rate of von Willebrand's disease? Yeah, oh, okay, well, so I know in studies that have looked at populations of different ethnic backgrounds that East Indians are very similar to Caucasians in von Willebrand's disease. So if you have an adolescent coming in with heavy menses, this is going to be up to 40% of the time you're going to have this diagnosis. So I don't know if that's true in Indonesia, but it can be a very high diagnosis in a teenager that's coming in with extremely heavy menses. So this is something that we think about in our population. And overall, if this is an overall, not just adolescents, but overall it's about 20%. So in teenagers, it goes up even more. It's double that amount. Now, the thing that I get asked about a lot is because we use birth control to help with heavy menstrual periods, and oftentimes I get asked, well, I don't want to put her on an estrogen progestin method because that'll increase her risk of blood clots. That is not a consideration with von Willebrand's disease. Von Willebrand's makes you bleed more easily. It doesn't make you clot. So you can absolutely use those hormone methods for treatment. So infection, interestingly enough, pelvic inflammatory disease can show up as abnormal menses, either heavy flow or intermenstrual bleeding. So this is something that you should think about as well. And cervicitis can cause intramenstrual bleeding, so people can get kind of some spotting in between periods. So even though they're having regular periods, they're having some spotting in between, and this can be a cause of that. So there's some other anatomic problems that then also cause amenorrhea, so cervical stenosis, imperfect hymen, transverse vaginal septum, and then of course Asherman's syndrome. So imperfect hymen, oftentimes you can see that by having a bulging, kind of almost septum looking, and if you ultrasounded them, you can see that this huge amount of blood up in the uterus. This is the up into the uterus here, and then this is the vagina, so the vagina can really expand, and so that's all blood, which can be really uncomfortable for patients. Okay, so what else causes bleeding? These are not common in adolescents, but you could have a cervical polyp, you could have benign tumors, leiomyoma, adenomyosis, cancer, but all of those are things that you don't really think about in teenagers. So, okay. All right, so what if you don't have ovulation? So you talk to her, you ask her questions about her period, and you come up with, I don't think she's ovulating regularly. You know, what are you worried about? So then you got to worry about stuff that's higher up, right? So what's not talking to the ovaries? The head's not talking to the ovaries. So if ovulation isn't present, then you may be getting into getting some lab tests, right? So, and the lab tests that we think about are, okay, so we want to know what's going on. Is it, you know, everything's not working, some things aren't working, like what's happening, because that'll help you. So if you got FSH, LH, and estradiol, you know, what's happening with each one of these, and that kind of helps then get you into the right place with what might be going on. So what's the differential for that? So if you have no bleeding happening, if you have hypothalamic issues, then that's like weight loss gain, excessive stress, chronic disease, narcotic overuse, which doesn't really happen outside the US. This is a big problem for us. Or Kallman's syndrome, which is unusual but happens. These folks oftentimes do not have a sense of smell too, so they have a smell issue. So something basically is happening in their brain. And then pituitary, so hypothalamic or pituitary, you might have a pituitary neoplasia or empty sella syndrome. All of these are kind of rare, right? The most common thing that we see is kind of this in teenagers. So excessive weight loss, you know, so eating disorders, or excessive stress where they skip their period. We also see female athlete triad. So we have extreme, I come from the state where Nike, you guys know Nike? So Nike's headquartered there, and we have a lot of extreme runners. So oftentimes we'll see folks come in because they're exercising so much, and then their body fat's so low that they'll stop having their menses. And that's problematic because then they're also, they can get bone fractures. And then what if this is due to the ovary? So this stuff is working, but your ovary isn't working. So like your head is telling your ovary to work and your ovary is not working. Like what's happening there? So they could be in menopause, not something for teenagers, but we do see premature ovarian failure. You can see this with Turner syndrome patients. They're more likely to have earlier or inconsistent premature ovarian failure. And what's interesting is premature ovarian failure is not as complete as we thought it once was. It used to be something where we said, okay, that happened to you. Your ovaries no longer going to put out any eggs at all. And actually, there might be some inconsistent pulses that happen. So those women still actually need contraception if they don't want to get pregnant. Although sometimes you're using contraception to help give them some hormones back too. You could have some genetic disorders happening too as well. So that's something where, so again, if you're ovulating or not ovulating, so this is the group that's not ovulating, and is it the head in the two different places, or is it the ovary not working? And then, you know, maybe your lab tests are all fine, and then that's basically everything's kind of working generally okay, but it's that stress, weight loss issue, or maybe weight gain that kind of happens. And then pituitary, you can have all sorts of things happening. Now, thyroid is under pituitary, but basically it's more kind of a overall medical condition that happens, but typically you need to be either really hypo or hyper to have a problem. And then ovarian, you can have polycystic ovarian disease, but interestingly enough, in teenagers, there's no diagnosis of polycystic ovarian disease because a lot of the things that happen with teenagers or adolescents are very consistent with polycystic ovarian disease, so you can't really diagnose it well until they're older. So there is no diagnosis of polycystic ovarian disease for adolescents. Okay, so we're going to go into teen pregnancy because that is the most common thing for menstrual dysfunction or disorders. And what's really important about teen pregnancy are teens are at very high risk for having maternal morbidity and mortality with a pregnancy. So we know that actually their maternal morbidity and mortality is higher. They have higher incidences of needing surgeries, of having hypertensive disorders during pregnancy. We know they have a higher risk of premature birth, stillbirth, ongoing health effects, especially in low middle income countries with having obstetric fistulas. And then also socially this impairs their life for ever sometimes because of education disruption. And then also we know that their babies are at higher risk for having poor health outcomes too. So all in all, this is not a great thing for young women to become pregnant and to have a child. So teenage pregnancy worldwide, it varies, and basically you guys are in kind of this area here. And in the Far East, we're still having high rates of unplanned pregnancy in teens and teen pregnancy. Some of that is affected by the age of marriage that's culturally appropriate in countries. But interestingly enough, some countries we may not be getting full data on because they only report married women and not unmarried women, which unmarried women still get pregnant too, so they're still an important group to know about. We know that basically from WHO data that about 16 million adolescent girls become pregnant globally. And again, we talked about that basically this affects everything that happens for them, but it also is a thing that happens disparately, so it happens more often in poor and rural women. And we are still having problems with it around the world. So I just happened to be on the web and was looking to see if I could find any pregnancy data for Indonesia specifically, and I found this Jakarta post from a couple years ago in 2016 that said teen pregnancy rates remain high in Yogyakarta, which you guys probably know because this is where you're based. And you know, this is an issue in the United States too as well. We have a high rate of teen pregnancy too. So overall, the data for Indonesia that I could find was from a couple years ago, but it does look like the number of births that are happening are less over time, but these extreme disparities, so poor And rural women, it's happening more often than folks that are urban, have more education. And again, the unmarried women are not included in the country statistics, so it would be interesting to know kind of what the actual rate is overall, just not based on marriage, but just based on age. And I know this is a sensitivity issue here and in many countries about the married, unmarried numbers. And then I believe you had a change in marriage age here, and so that may be affecting some of the rates too as well. So we have to take that into account for different countries depending on what the marriage age is, because it may be more acceptable to have adolescent pregnancies, but then at the same time their risk doesn't really change much in terms of health risk. Their economic risk may not be the same because they're supported in their family, but their health risk may be very different. So there are several strategies that the World Health Organization is focused on with teen pregnancies, and these, I'm going to just review these with you, and you can think about kind of in the context of Indonesia how those might work. So one of them is to reduce marriage before age 18, and I think Indonesia is 16, right? So this has been put in place because it helps kind of prohibit early marriage, and then also it keeps girls in school longer, which is important for overall economics for women. And then also we do know that as women age, some of the things that happen in pregnancy, their risk goes down, like hypertension and things like that. So, so there are some health reasons for this too as well. Making sure that basically women are educated about when to get pregnant and what's safe to do. So education of women, increasing use of contraception for women and having the access available for them. And interestingly enough, you can see here that there's a very high unmet need for women. And this is just married women. So we know that unmarried women also have sexual activity that happens and are at risk for pregnancy. So this is probably much higher if you're looking for all women, but this is just married women. And you can see here for South and Southeast Asia that when you look in the different age groups, so the light purple bar on the top is the younger age group, they have unmet need, and then it actually grows as you get older. But overall, there's a huge unmet need for women in general in all countries for contraception. Decreasing coerced sex, so violence for women, is a strategy outcome. Reducing unsafe abortion, so if you had sex that happened and then you got pregnant, making sure that you're safe if you need to end a pregnancy. If you are going to have a pregnancy and you're continuing your pregnancy, that you have safe care around your pregnancy and safe care afterwards. And that gets us to youth-friendly services. Do you guys have a youth-friendly service here? No? So there have been studies that have actually shown that adolescents don't find the healthcare system friendly to them. And probably most people would say that's true of a lot of things, but in particular in adolescence. And we know that young women and young men actually don't use contraception well or don't have access to it. They have higher rates of unintended pregnancy because they don't have access to contraception or education around it. They have higher rates of sexually transmitted disease because they're not using something to protect themselves because they don't have the information or access to do that. And then they have higher rates of sexual violence exposure. So there are studies that show that we don't have a health system anywhere really that makes it inviting for adolescents to come into the healthcare system to get treatment. So there's a lot of movement around youth-friendly services. In fact, in Bangladesh, they have national guidelines to create youth-friendly services, especially in reproductive and sexual health care. So something to consider as we move forward to try to decrease the rate of unplanned pregnancies and pregnancies in adolescents. So there's 5 key components that the World Health Organization has set out. and that's making sure that health services are equitable, meaning that basically it's like any kind of health service that they might need, that they're accessible, that they're acceptable, that they're appropriate, and that they're effective. So it's kind of like any healthcare somebody would need, but specific to youth. These are some of the things that we can do to kind of make youth-friendly services available, and some of this got cut off, but basically thinking through the health system of like what the health structure is, what the provider's like, and then also what's available to them. And what's interesting is the Centers for Disease Control in the US kind of put out this little infomatic about what a health-friendly clinic looks like for teenagers. This is just available publicly to really translate the WHO concepts into what the actual clinic looks like. And they've really set out like confidentiality, privacy, because teenagers really want that, making sure that teenagers can consent to the care that they get, that they have respect and comprehensive services. So from HIV to Pap smears to vaccines, like anything that they could want to get there. If they want a parent to be involved, that they could have one, but they don't need to. And then really, because teens are in school or getting educated or having to work or whatever happening, they need flexible clinic hours. They need to be able to schedule easily, or maybe just even show up and not have scheduling happen. They might need it to be free and not have to pay, or be really low cost because they may not have any money. So just different things around kind of availability of services for them. I'm just going to talk about moving to kind of contraception, a program that happened in the US that has really opened the eyes around having full access to the different types of contraception for teenagers. Because I would say around the world, oftentimes we don't use IUDs in teenagers. Do you guys use IUDs in adolescents here? Yeah. People are like worried about it. They're like really worried. And actually being a young woman doesn't make the risk of using an IUD any different than if you're older or had children. So what really brought this home in the United States is we had a study of 10,000 women where they had to come in and they had to either change their birth control or use a new birth control. So if they weren't using anything, they actually had to start a birth control, and they had everything available to them for free, which you guys probably have contraception for free in here sometimes. We do not. You have to pay for it, and it's very expensive. So basically they said, you can have all of this for free. We're going to counsel you on the different types. It doesn't matter what your age is. You can have any of these as long as you don't have a contraindication. And age doesn't matter. That's not a contraindication. So what was interesting is they had thought that maybe like 7% of women would choose a long-acting method, like an IUD or an implant. And what happened is they had a huge number. So basically, 58% of women chose an IUD in all women, and 17% chose an implant. So the rate of IUD use in the United States is like 11%, and the rate of implant use is probably like 3%. So they had a 58% use of IUDs. And then in adolescents, they had 35% choosing IUDs and 34% choosing implants. So the majority of people chose long-acting methods, whether you were a young woman or you were older. And this just went to show when we took out barriers that women actually chose long-acting methods. So if we counseled them about all of it, and then also they were offered the IUD or the implant on the same day. So they came in and they could get it the same day. Also what we found is that basically the continuation rate, no matter what your age, because people were like, adolescents, they like stop their method right away. Like they'll get it and then they'll have it taken out. And basically here you can see for the two types of IUDs that we have in the US and the implant, that the continuation rate was really the same no matter what the age group was. And then actually the continuation rate for all short-acting methods was really bad, So when you were looking just at continuation rate with short-acting versus long-acting altogether, again, you can see here that it didn't really matter what age you were. You continued it for a long time, and fair enough. After 2 years, teenagers might not have had as high of a continuation rate, but that's for 2 years. That's 24 months. So they really kept their method. And then what we found is, what was really interesting is, okay, we normally say the pill works like 92%, unless you look at the package insert and then it says 99% because that's perfect juice. But are you guys perfect? No, nobody's perfect. But we thought that pills actually worked much better than we thought. But in actuality, in teenagers, we know that that teens who use short-acting method actually have a very high risk of pregnancy happening. So anybody that used a short-acting method actually had a higher risk of pregnancy. And folks that used a long-acting method, no matter if they were young or older, actually had very high pregnancy prevention. So this is just showing that if you give women kind of all methods and you counsel them about their choices and you have it available to them, a lot of women will choose long-acting methods, and actually that prevents pregnancy. I think it's just important to have kind of materials for teens if you are providing contraception that speak to them. We have different materials in the US specifically for teens that kind of relate how well something works. So this is the ladder, or the contraceptive ladder. So this doesn't work as well, this works pretty well, and this works really well. And then just relating it to how many women get pregnant in a year if you're using each of these methods. And this is available for you guys, and I'm sure if you wanted to translate it into Indonesian, you could do that. There are two kind of worldwide global resources for contraception. Have you guys heard of the medical eligibility criteria for contraceptive use? So the WHO has the medical eligibility for contraceptive use, and then the selected practice guidelines. So the medical eligibility criteria for contraceptive use is really who can use it, like if you have a medical disorder, like what method you can use safely, what you can't. And the selected practice guidelines are how to use it. Like if you have somebody who is missed a pill, like what do you do about it? If you have somebody who is having bleeding on their IUD, what to do about it. So really it tells you different ways to kind of manage that. So those are two global resources for you guys. I think there's now an app for the WHO medical eligibility criteria that you can download. We also have a US-based medical eligibility criteria, so we use that one. And the WHO really meant this to have countries take this and make it their own, because there may be specific things in a country that are different than other countries. But what's interesting in this is there's almost nothing that's based on age that you can't use something. It's all based on medical conditions. And these are the kind of the conditions that they give you. So 1 and 2, basically people can use it. 3, you have some concerns. And 4, you should probably not use it. And I'll just end there. So that's it. All right, thanks.